Thank you. I wanted to thank the Neurosurgery Publications Group for allowing us to present this material and for accepting our recent publication. I'd also like to thank our co-authors for this very important work. My name is Jim Harrop, and today I'm going to discuss acute implantation of a bioresorbable polymer scaffold in patients with complete thoracic spinal cord injury, a randomized control trial, also known as the INSPIRE 2.0 trial. Unfortunately, there are no proven effective treatments that exist for traumatic spinal cord injuries. We do know from preclinical data that implantation of a highly porous, biodegradable investigational device or a neurospinal scaffolding can result in improved neurologic function as well as proved histological data. If we look at the slides below, under the control group, unfortunately, after a spinal cord injury, the body tries to inhibit neural regeneration. It does this by building a scar around the injury, and subsequently a cyst forms. With this novel biodegradable investigational device, this was placed into the spinal cord after opening the spinal cord up in order to improve neurologic recovery. And this is what we saw in rodents. So this translational work was brought together. INSPIRE 2.0 was done, and this was a prospective randomized study. Again, open label, single arm, multi-centered with 11 sites. 19 patients with Asia A thoracic spinal cord injuries underwent the trial, where 10 of them were implanted with biodegradable scaffolding. At primary endpoint, 6 months, Asia conversion rate occurred in 44%, or 7 of the 16 patients. This exceeded historical controls. There was also no unanticipated or serious adverse events, and this was up to 2 years after the studies. Basically, just to recap on how this is done, after the patient has their spinal cord injury, they're taken acutely to the operating room within the first week. The spine is exposed and the dura is opened, identifying the contusion as seen as in the top left corner as the brown area. The pia, or the surrounding tissue around the spinal cord, is then incised and opened. Interesting, what we noted was in this cystic cavity was a large amount of necrotic material, which was under pressure. This was then irrigated out, leaving a void or hole in the spinal cord where this scaffolding was then placed and the dura was subsequently closed. Again, just to review, 20 patients were screened. Of those enrolled, they were randomized either to the scaffolding or the control group. One patient unfortunately passed away in the control group, and analysis consisted of looking at the results in both groups. Unfortunately, there was not a significant difference in our primary outcomes. Again, only 20% of the scaffolding patients converted, or 2 out of 10 patients, were in the control group, 3 out of 10 patients converted. However, there was also no unanticipated adverse events or serious adverse events related to the scaffolding or the implantation procedure. So in conclusion, this is a small randomized control trial. Implantation did not produce probable clinical benefits, but it also did not show any significant deterioration or adverse events. This is a very important point because we were able to show in the acutely traumatized spinal cord, an acute intervention can be done on the spinal cord without significant neurologic deterioration. I and my co-authors thank you, and we appreciate your time.